Operative vaginal delivery is the deliberate use of mechanical devices to assist and expedite the second stage of labor. By applying external traction or rotation, the procedure is designed to closely mimic the mechanics of a spontaneous vaginal birth. This data visualization highlights a consistent reality in modern obstetrics. In regions with standardized protocols like the UK, the incidence of these operative deliveries remains highly stable at 10 to 13%, consistently yielding safe outcomes for the majority of mothers and babies. The alternative is often a cesarean section performed late in the second stage of labor. Proceeding to surgery at this depth of engagement carries significantly higher rates of major obstetric hemorrhage, prolonged maternal hospitalization, and neonatal admission to the intensive care unit. To avoid those surgical risks, obstetricians rely on two primary mechanical tools, the obstetric forceps and the vacuum extractor, known as the Ventouse. Looking at this side-by-side comparison, we can see how each instrument interfaces with the fetus. The required biomechanical force is applied in completely different ways. Forceps firmly grip the lateral sides of the fetal skull, whereas the vacuum extractor adheres directly to the superficial cranium. Professional competence in the delivery room requires matching these distinct mechanical advantages to the specific anatomical presentation of the fetus. When labor stalls or fetal distress occurs, operative vaginal delivery serves as a vital safety valve, converting a high-risk scenario into a controlled extraction. Before any instrument is introduced, strict physiological prerequisites must be met. The cervix must be fully dilated, the amniotic membranes must be ruptured, and the fetal head must be definitively engaged in the maternal pelvis. To standardize this process, the American College of Obstetricians and Gynecologists classifies operative deliveries based on the precise spatial location of the fetal skull. This anatomical diagram maps the fetal station relative to the maternal ischial spines and the pelvic floor. An outlet delivery is the most straightforward classification. At this stage, the fetal scalp is visible at the introitus without parting the labia. The skull has reached the pelvic floor, and the head requires less than 45 degrees of rotation. Conversely, a mid-station delivery introduces significant complexity. Here, the fetal head is engaged, but the leading point remains above the +2 centimeter mark, requiring a calculated extraction path. If the fetal head remains high and completely unengaged, operative vaginal delivery is strictly contraindicated. The distance and angle present an unacceptably high risk of maternal trauma and fetal injury. Mechanical intervention is only deployed when the biological geometry of the second stage provides a clear, viable pathway for the selected instrument. When rapid, high-force extraction is required, the obstetric forceps are utilized. These consist of two articulated metal blades engineered to securely enclose the fetal head. A standard long-curved forceps features a highly specific dual-curve design. The pelvic curve conforms to the sweep of the maternal birth canal, while the cephalic curve is contoured to hold the fetal skull. Because left and right blades differ, clinicians perform a protocol known as ghosting. The operator holds the articulated instrument outside the perineum in the exact orientation it will assume internally, ensuring precise blade identification before insertion. Once correctly applied, the handles will lock easily. The blades will sit equidistant from the lambdoid suture, creating a secure biparietal grip that stabilizes the skull. This grip creates a mechanical advantage. The forceps act as a rigid protective cage, capable of safely transmitting up to 20 kilograms of traction force directly to the solid base of the fetal skull, bypassing the fragile cranial bones. This caging effect makes forceps mandatory for highly vulnerable deliveries. For preterm infants under 36 weeks, or in complex face and breech presentations, the rigid blades shield the immature or uniquely positioned cranium from the compressive forces of the birth canal. However, this mechanical power carries maternal risks. The physical bulk of the metal blades increases the likelihood of vaginal lacerations, cervical tears, and even severe nerve injury during deeper mid-station deliveries. Forceps deliver high traction and unmatched speed during acute fetal distress, but they demand a significant amount of space within the maternal pelvis to operate safely. If the clinical priority is minimizing maternal trauma, the Ventouse is typically selected. This device does not occupy space in the birth canal. Instead, it generates a vacuum between a suction cup and the fetal scalp. The physics of the extraction differ entirely from forceps. Rather than pushing from the skull base, the ventouse relies on superficial suction to drag the cranium downward along the axis of the pelvis. This suction draws the fetal scalp into the cup, forming a temporary, localized swelling known as a chignon. Depending on the exact clinical need, operators can choose between rigid metal cups or softer, celestic materials that reduce superficial scalp trauma. The primary biomechanical advantage of the vacuum is auto-rotation. Because the cup is attached to a single point on the vertex, the fetal head is free to rotate naturally as it navigates the internal curves of the pelvic floor. This low-profile mechanism is highly efficient. It requires significantly less maternal analgesia, often just a local pudendal block, and results in fewer severe lacerations. But the ventouse has strict physical limits. It is absolutely contraindicated for premature fetuses under 34 weeks. At that gestational age, the superficial suction poses a critical risk of scalp avulsion and severe subaponeurotic hemorrhage. For full-term vertex presentations requiring minor rotation, the ventouse minimizes maternal tissue damage while effectively assisting the descent. The decision tree for operative delivery is highly structured. This checklist summarizes the protocol. The ventouse is prioritized for term deliveries requiring rotation with minimal maternal trauma, while forceps are reserved for rapid, high-traction extractions or cases requiring cranial protection. Crucially, obstetricians are cautioned against using both instruments sequentially. Transitioning from a failed vacuum to forceps exponentially increases the risk of severe mechanical trauma to both the mother and the neonate. When an instrument is applied but fails to expedite the birth, it is classified as a failed forceps or failed vacuum delivery. This typically occurs due to an unrecognized malpresentation or cephalopelvic disproportion, where the fetal head is simply too large for the maternal pelvis. In rare cases of severe, neglected obstruction, where the fetus is already deceased, destructive operations like a craniotomy are performed. These procedures surgically reduce the bulk of the fetal head to allow extraction and prevent a catastrophic uterine rupture. Operative vaginal delivery represents a direct mechanical solution to a biological arrest. By meticulously matching instrument engineering to the spatial realities of the maternal pelvis, clinicians can safely guide obstructed labor to a successful completion.